Good evening, everyone. On behalf of our President, Dr. Pragnesh Shah, and our Honorary Secretary, Dr. Pragnesh Vacharajani, the dynamic and versatile pair or duo as we call them, I welcome you all, Dr. Preeti Shankar, the Academic Committee, welcome you all to this series of webinars on endocrine disorders. And as you all know, we have regular programs, more than two in a month. And this is a series we have started on endocrine. And we have none other than Dr. Om Lakhani with us. And to introduce Dr. Om Lakhani, we have Dr. Sanjay Shah, our academic committee person, to introduce Dr. Om and take the proceedings. Thank you all. Welcome you all once again in this hot summer.
Thank you, madam. It's my pride and privilege to introduce our own doctor, Dr. Om Lakhani. Today, he is going to talk for the second time in Ffpai. As you all know, Om Lakhani is consultant endocrinologist and attached with Zydus Hospital, Ahmedabad. He has an outstanding academic record with gold medal in UG and PG exams, winner of different awards also. But after all, he is a man of technology. He is also developer of an app Notes in Endocrinology, and he is also running one website www.endocrinology.co.in. Today, you also will see that Dr. Om Lakhani is a man of endocrinology and technology both. And today, he is going to talk on the subject type 2 diabetes. We are treating the wrong disease. Means understanding type 2 diabetes from an ectopic fat perspective. So, I welcome Dr. Om Lakhani to give his talk.
Thank you so much, sir, Sanjay sir, and thank you, Dr. Preeti madam, for the kind introduction. And thank you to this forum for having me once again for this very interesting talk. And today I'm going to take you to a journey through understanding diabetes from a different perspective. So that is what we're going to discuss today. So, I'm sure it's going to be very interesting and exciting for everyone. I'm actually very, excited to present this because this is something which is just been in my mind for a long time. And, this is something I would really like to share in terms of my understanding and perspective of diabetes. So Rahul, is my screen visible? Okay, thank you. So what we are going to talk today is type 2 diabetes. We are treating the wrong disease. And we are going to see type 2 diabetes from a completely different lens today. We are going to see it from the lens of an ectopic fat. So as I go along this talk, you will understand what I'm trying to tell you. But before that, let me start with something, we are just, there was a discussion in one of the WhatsApp groups. Very interesting discussion, but there's one line which really stood out, and this is what I'd like to share. I'm still laughing about it, right? That's why, before I need to get this off my mind. They said one patient went to a doctor and says, the doctor tells the patient that आपको थोड़ा मीठा कम खाना चाहिए. Patient बोलता है क्यों? तो doctor said that, मीठा कम खाने से जिंदगी लंबी होती है. So the patient replied back saying that, doctor साहब, मीठा खाने से जिंदगी लंबी नहीं होती है, जिंदगी लंबी लगने लगती है. Right? So that is often from the patient's perspective that, but we are going to see this from an ectopic fat perspective. We are going to see this from a pathophysiological perspective, not from the doctor's perspective, not from the endocrinologist's perspective, but from the real pathology perspective. So let me then begin with the foundational question. What is diabetes anyway? Now, if some of you follow me on, we have a YouTube channel as well called Endocrinology India. Sometime back, we had given a talk called Unifying Theory for Pathogenesis of Diabetes. It's like unifying theory in physics, right? We all know about Einstein's unifying theory for physics. Same way, this is a unifying theory for understanding the pathogenesis of diabetes. What I wanted to say in this talk was that for all forms of diabetes, whether you're dealing with type 1 diabetes, whether you're dealing with type 2 diabetes, or you're dealing with other forms of diabetes, diabetes is a disease of an imbalance between insulin resistance and insulin production, that is the beta cell function. So the difference between the body's ability to have insulin resistance and body's ability to produce insulin is what ultimately leads to diabetes. So think of any diabetes and you'll find this perspective to be true. For example, in a situation called euglycemia meaning normal blood sugar, the insulin resistance and the beta cell function are equal. That means the amount of the insulin that is produced and the resistance which is there is in line, and that's why the patient is able to maintain euglycemia or normal blood glucose. But what happens when the patient has hyperglycemia? In any situation when the blood glucose is high, in any of that situation, either the beta cell function is less or insulin resistance is more, or it is a bit of both. That means whenever the insulin resistance is more than beta cell function, that is what leads to high blood sugar. Now, it could happen in 3 different scenarios. Okay, so if you understand the current classification of diabetes based on this unifying theory, we'll have 3 broad perspectives. Okay, so let me first deal with that and we'll deal with the individual disease. So there are 3 possibilities. So I said that when insulin resistance is more than beta cell, or insulin resistance is more than, let me say this way, more than insulin production, that is what leads to hyperglycemia. Now here couple of things can happen, right? One, the insulin resistance is very, very high, and insulin production is normal. Okay, so let's say there is a situation where insulin resistance is very high, but insulin production is generally normal. Naturally, this will also lead to diabetes, right? This type of situation does not happen in type 2. This type of situation happens in a very rare conditions called lipodystrophic syndromes, where there is insulin resistance or severe insulin resistance syndrome. There are many insulin resistance syndromes where the insulin production of the patient is normal, but the insulin resistance is very high. Second scenario is when you have insulin resistance is some about normal, but insulin production is less. Okay, insulin production is very less. This type of situation happens very commonly in what we know as type 1 diabetes. Also happens in pancreatic diabetes, right? So in both this condition also, in some cases there is a little bit of insulin resistance, but more or less the main defect is insulin production and not insulin resistance. So this type of situation happens in type 1 and pancreatic diabetes. But the most common form of diabetes, that is type 2 diabetes. In type 2 diabetes, what happens? Type 2 diabetes, there is increased insulin resistance and reduced insulin production. There is both. Okay, so insulin resistance is also high and insulin production is also less. Both the things happen in type 2 diabetes, and that is something which is very important for us to understand. Now, going into more detail, in a pre-diabetes situation, what happens? So initially, in early stages, that is in a pre-diabetic situation in type 2 diabetes, the blood sugar is generally normal. You don't have hyperglycemia, right? Just have a mild hyperglycemia. In this situation, the insulin resistance is high, but the body is able to produce enough insulin to compensate for the insulin resistance. Okay, so insulin resistance in this situation is high, but the insulin production also increases to match the insulin resistance, and this is what happens in pre-diabetes situation. Now, if you go in early diabetes situation, what happens? Initially, the insulin resistance keeps increasing, and slowly the body's ability to produce insulin, that is beta cell function, starts reducing. And when the beta cell function starts reducing, either it reduces very slowly, where you can have a mild type 2 diabetes, or sometimes it reduces very rapidly, that leads to a very severe form of early type 2 diabetes. And on a long stage, there is a glucotoxic situation happens, that the high blood sugar leads to polyuria, polyphagia, leads to increased calorie intake, leads to more blood glucose, leads to more beta cell dysfunction, it leads to further insulin production, and this leads to a vicious cycle. And over a period of time, in late type 2 diabetes, the insulin resistance becomes static, but the beta cell function continues to decline. And that is what ultimately the patient, even with type 2 diabetes, will require insulin over a long period of time if things are not maintained properly. So this is what happens in all diabetes. So if you see the journey sequence of type 2 diabetes, there is a genetic risk. Initially, there is compensation, that is to match the increase of insulin resistance. The body produces more insulin, so there is a compensatory phase. But eventually, because of chronic inflammation, glucotoxicity, lipid toxicity, amyloid deposition, inflammation, all the situation, the beta cell production of insulin reduces. And when you have a state where the insulin resistance and insulin demand and insulin production is a mismatch, that is when you start developing diabetes. And as the diabetes advances, the insulin production keeps declining, whereas insulin resistance becomes static. So that is what typically happens in type 2 diabetes, right? So what I'm trying to say, and this is the ultimate point which you have to understand, that I repeat this once again, type 2 diabetes is not just a disease of insulin resistance. It's a disease where you have increased insulin resistance and decreased insulin production, right? You have both this situation, right? And when you have both this situation together, that is what ultimately leads to type 2 diabetes. Okay. Now, I started my talk by saying that we have completely misunderstood type 2 diabetes. Why have we misunderstood diabetes? And that is what I would like to really discuss. And I'm going to discuss this point again and again, but let me first get to this point right at the beginning. So why we have misunderstood type 2 diabetes? Because if you see this journey over here, right? If you see this chart over here, and I'll rub all these things drawings which I made. I'll just show you this chart which is there in front of you, right? Very elegantly made picture. Here it is showing that in the pre-diabetes stage, there is increased insulin resistance, and then ultimately there is a decline in the beta cell function. And this is the point where we diagnose as diabetes, right? Now the patient comes to us in this stage, okay? Patient comes to us in this stage. That is already when the beta cell dysfunction has started happening. So the disease is recognized in this stage. Of course, a lot of time if you see patient's report also, patient already was having pre-diabetes or patient was already having signs of insulin resistance, but we did not do anything for that patient. Now, if you see technically we are right? We'll start treating the patient only when the blood sugar starts increasing, right? We start treating the patient at this stage, right? When the blood sugar starts increasing. But what we forget, and what is very important for us to understand, is that the clock for complication actually started in this phase itself. In the pre-diabetes stage itself, the complications for diabetes had already started. So the time to act was not here, time to act was here. This was the time when you had to act. And this was the time we failed to take any action, and because we failed to take any action, and what happens is, and this is a very important point you have to remember, the point is that, and this is a very fundamental point I'll tell you, the insulin resistance and the other problems ultimately lead to the macrovascular complications of diabetes, right? The macrovascular, that is the heart disease, coronary artery disease, stroke. These are all complications that happen as a result of insulin resistance. And the beta cell dysfunction, which eventually happens, this is what leads to microvascular complications. This is what ultimately leads to the retinopathy, nephropathy, neuropathy, right? Now, most of our diabetes understanding is focused on this microvascular complication, but we forget that the life of the patient is dependent on this macrovascular complication. The patient will not die of retinopathy. Patient will die of coronary. I'm not saying that retinopathy is not important. It is important, but the patient is more likely to die because of coronary artery disease and stroke than he is likely to die because of retinopathy and neuropathy. Even with nephropathy, most patients with diabetic nephropathy die because of heart disease and not because of the kidney disease. So this is something which is very, very, very important to understand and very, very fundamental to fathom, that because of how type 2 diabetes was recognized and how you had all these trials like UKPDS, etc. Our focus has always been on microvascular complication. However, our focus should be on the macrovascular complication. and not the microvascular complication. It should be on microvascular, but the major focus should be on macrovascular complication as well. And we lose this sight and we only start treating the patient when he comes in this stage. When even if we do a good job, we prevent the microvascular complications and to some extent reduce macrovascular complication. But so the phase where you have to treat is the early type 2 diabetes or the pre-diabetes stage. This is the stage where you have to start treating the patient. By treating the patient at this stage, you are able to not only reduce and prevent diabetes from happening, not only prevent the patient going into the microvascular complication eventually, but you will also prevent the macrovascular complication. Right? So this is something which is very, very fundamental and very, very important, right? And this is why I always said that we have misunderstood type 2 diabetes. We have misunderstood type 2 diabetes. We have thought that type 2 diabetes is only a disease where you can prevent microvascular complications. But because we have started treating the patient too late, if we treat at the right time, if we recognize the disease at the right time, we can even prevent macrovascular complication, and that is something which you should aim at. The second fundamental mistake that we make is the same mistake which I started when I started the talk, right? I'll now contradict myself. I started by telling you that type 2 diabetes is a disease of imbalance between insulin resistance and beta cell function, which is right. But type 2 diabetes is technically a disease of ectopic fat. And this is ultimately what I'm going to talk about in the rest of the talk. And this is where I'm going to go a little further. So at the core, and this is the major problem thing, right? At the core, the problem is not insulin, the problem is not blood glucose, the problem is the disease is ectopic fat. This is the disease. This is the fundamental disease that we have to recognize, and this is the fundamental disease that we have to treat. Now, why ectopic fat and how ectopic fat contributes to both diabetes as well as the diabetes related complication. Now you have ectopic fat which is deposited in the liver that leads to central insulin resistance. We all use metformin for diabetes, right? Metformin acts in this part. This is where metformin acts, right? Metformin is the first drug we use in diabetes, and metformin is something which acts here. Then you have ectopic fat in the pancreas, and this pancreatic fat leads to the beta cell dysfunction. It is one of the mechanisms by which it leads to beta cell dysfunction. And the fat in the adipose tissue and muscles leads to peripheral insulin resistance. And this is where ultimately you have pioglitazone, right? Some of your drugs like pioglitazone, right? So basically what you are seeing is that the disease of diabetes itself, the pathogenesis of diabetes itself can be explained by ectopic fat alone. So you have ectopic fat in the liver, ectopic fat in the pancreas, and ectopic fat in the muscle and adipose tissue. And ultimately a combination of these ectopic fat is what leads to the disease, right? So type 2 diabetes is a disease of fat and not a disease of glucose, right? That is something which is fundamental and we have to understand. Now you'll ask me, Om, what is ectopic fat? What is visceral fat, right? Now, whenever you see somebody, right, and this is something called as a sumo wrestler paradox, right? You have the sumo wrestlers. You would have all seen sumo wrestlers, right? Sumo wrestlers are this big giant wrestlers from Japan, right? Now a sumo wrestler looks visibly, very obese, right? But if you see, a sumo wrestler is actually more fit than a lot of us. This is also something which Dr. Yajnik called as YY paradox. So Dr. Yajnik and one of his colleague who was a Caucasian, both of them had similar BMI. But when they did a DEXA of both of them, they found that Dr. Yajnik actually had more visceral and ectopic fat compared to Dr. Yudnik, who was having the same BMI, but had more subcutaneous fat and less of visceral and adipose fat, right? So who of these is more likely to develop diabetes? It is Dr. Yajnik, because he has more ectopic fat. So fat under the skin is fine. Fat under the body is ectopic fat or visceral fat, and that is the fat which is active, and that is the fat that leads to disease. So ectopic adipose tissue is the fat that accumulates around the major organs of the body or within the major organs of the body. It is not supposed to be generally deposited there, but when the fat is in excess, it starts getting deposited in the ectopic area, and that is what is ectopic fat. Visceral fat is the fat that is stored in the abdominal cavity around the vital organs in the omentum. This is the visceral fat. Actually, visceral fat itself is a type of ectopic fat. Okay, so this is what you understand by ectopic and visceral fat. So you can see in this picture, the visceral fat is so subcutaneous fat is fat under the skin, which makes you look obese. But ectopic fat is under the skin, under the body, right, inside the body. And this is the visceral fat, and this is what makes you sick, right? This is the fat which makes you sick. Subcutaneous fat makes you look fat, whereas a visceral fat is the one which makes you have the disease, right? Some people have both, right? Sumo wrestlers are different. A lot of obese people have both ectopic fat and visceral fat and subcutaneous fat. But some people predominantly have subcutaneous fat who look fat, but they are not that, they don't have a disease. Whereas some people, you would have seen that a lot of people are fat, but they don't have diabetes. But some of the people are not that fat and they have diabetes. So the difference basically lies because of the visceral fat, right? The visceral and ectopic fat, that is what ultimately determines those people who are more ectopic in visceral fat have more likely to have diabetes. So this is the fundamental thing, right? And why does visceral fat lead to diabetes? That's again a pathogenetic problem we are not going to discuss too much, but you have to understand that all of these ectopic and visceral fat ultimately lead to chronic inflammation. It leads to chronic inflammation, and this chronic inflammation, again, one of the fundamental mistakes that we make in understanding diabetes is that chronic inflammation is something we don't understand. Very important, you have to understand. Now there are a lot of trials also in this area. If you see NEJM and other journals, right, the chronic inflammation has direct link with atherosclerosis, right? And a lot of family doctors and a lot of physicians ask for HSCRP as a test, right? A lot of you ask for HSCRP. What is HSCRP? HSCRP is nothing but a marker of this chronic inflammation, high sensitivity CRP. And HSCRP, we use it as a marker of atherosclerosis, right? So ultimately you have to remember is that this chronic inflammation is ultimately what leads to atherosclerosis, and atherosclerosis is what leads to the heart disease, heart attack, stroke, etc., right? So this is the fundamental issue that you need to understand. Now, next I am going to not only make you understand diabetes disease itself happens because of ectopic fat, but the complications of diabetes also happen because of ectopic fat. Okay, how does that happen? So what you need to understand is that you have, even amongst these cells, even amongst the fat, you have healthy adipocyte and unhealthy adipocyte, or healthy adipose tissue and unhealthy adipose tissue. Now, you have in your body, so you have certain cells called adipocytes. The job of this adipocyte is to store fat, right? It is their job to store fat, right? Now, it does its job well, right? So when you have some amount of fat, it keeps storing this fat as much. So there are, and the thing is that most of us have a limited number of adipocytes, right? So the cells are, let's say we have 1,000 adipocytes. Of course, there are more, but I'm just saying, let's say there are numbers of 1,000, right? So as the fat starts accumulating in your body, fat starts getting deposited in these adipocytes. Okay, so fat get deposited in this 1,000 adipocytes. The fat start getting deposited. Now, when the fat is more than these 1,000 adipocytes can really accommodate, what happens? Does the body produce more adipocytes? No. So the ability of the body to produce adipocytes is very limited. To form new cells is actually very, very limited. So whenever there is more fat, instead of body producing more adipocytes, body keeps stuffing the adipocyte with the fat, right? So this adipocyte starts getting stuffed with the fat. And this stuffing, what it does, remember, these adipocytes are actually cells which are alive, right? It has its own blood supply, it produces its own hormones. And when you put this cell under stress, right, the cell starts dying and starts releasing reactive oxygen species, right? Starts producing a lot of inflammation. And so you have this adipocyte under stress, the unhealthy adipocyte expansion ultimately leads to the blood supply of the adipocytes is not able to reach up to the amount of fat that is deposited, and because of that, it starts becoming unhealthy, right? We all know that, a lot of cities, if the city expands a lot of people migrate to that city, then the crime in the city starts increasing. It's the same thing, right? That, this is like Mumbai city or Delhi city, right? When a lot of people migrate to Mumbai or Delhi, then what happens is that even though it's okay that people migrate, but the point is that ultimately, because there are a lot of migration and the city is not ready to take so many people, there are not many policemen, there are not many municipal people to help, there are not many law and order system. So because of that, the crime levels start increasing. Same thing happens in fat, right? So when you have a lot of migration of fat inside the adipocytes, ultimately what happens is that the fat starts getting deposited, and because of that, it leads to unhealthy adipocyte expansion. And this, after some time, what happens, the adipocyte starts releasing the fat into the circulation, right? And it starts releasing this free fatty acid into the circulation, right? So this is what ultimately it does. So this dysfunctional adipocyte starts liberating fat into the circulation in form of free fatty acid, right? So this free fatty acid, which ultimately starts getting released into the system, and then this free fatty acid starts getting deposited in various organs like the liver, in the pancreas, near the blood vessels, that is perivascular fat, in the brain, right? And this condition is known as lipotoxicity, right? This is called lipotoxicity, and this is what ultimately leads to a lot of the diabetes complications that we understand. Okay, so ultimately the ectopic fat, what happens, it contributes to lipotoxicity, it leads to organ specific insulin resistance and dysfunction and chronic inflammation, and ultimately these are all the conditions that lead to diabetes as well as the diabetes complications, right? Now we all have learned this, but never really understood. When I was in first year, I never understood what Rendell cycle was. I understood Rendell cycles after I became an endocrinologist, right? Even during endocrinology, I did not understand, right? This Rendell cycle is very simple to understand, right? If you understand just this thing. In simple words, what is Rendell cycle? Rendell cycle is that when there is excess of fatty acid, the body prefers using fatty acid as a source of energy over glucose. And hence, to avoid glucose being used, the body starts developing insulin resistance. This is simple concept of the Rendell cycle, right? So I told you that when the ectopic fat is under stress, it starts releasing the free fatty acid, and this free fatty acid gets taken up by the cells of these organs, and these organs start taking up this free fatty acid, and when they start taking up this free fatty acid, what it does is, when the cells are presented with free fatty acid, it prefers using fat as fuel rather than glucose, and to avoid glucose being used as fuel, the body develops insulin, the cells develop insulin resistance, and because of that, ultimately you have a lot of these diabetes related complications, right? So ultimately, insulin resistance happens at each of these organs. So you have insulin resistance at the liver, that is known as central insulin resistance. You have insulin resistance at the muscle, which is called peripheral insulin resistance, right? So these type of insulin resistance, and then you have at different organs itself, there is insulin resistance which develop. Okay, so and this insulin resistance, so you said that free fatty acid, now which part of the cell metabolizes free fatty acid? The mitochondria is the one which metabolizes free fatty acid. And when you have a lot of free fatty acid going to the mitochondria also starts becoming dysfunctional. It cannot keep up with this big supply of free fatty acid, and because of that, ultimately it leads to a lot of other complications as well. So there is mitochondrial dysfunction also, right? So ultimately this is what also leads to a lot of issues. Okay, so let me then summarize what I told you so far in terms of the understanding. Okay, so the problem, like I said, starts with the fat. Okay, so you have excess fat deposition in the body. This excess of fat, right, starts getting, clogged up into the adipocytes, starts getting packed, right? I think packed is a better word. So starts getting packed into the adipocytes, right? And this packing, right, ultimately leads to adipocytes under stress. Now, if you go further, this adipocytes under stress, it releases these fat into the circulation as free fatty acid, right? So it releases this as free fatty acid, and this free fatty acid starts getting taken up by organs, right? And these organs start taking up this free fatty acid, like for example, liver will start taking up this free fatty acid. Now, when the free fatty acid goes into the organs, the cells of the organs, the cells of the organs start taking this up, right? And what do these cells do, right? These cells, right, start using free fatty acid in preference to glucose, right? So this leads to two things: insulin resistance. Also, remember, free fatty acid is metabolized by mitochondria, so it leads to mitochondrial dysfunction. Okay, so and ultimately all these things lead to mitochondrial dysfunction. The insulin resistance lead to chronic inflammation, and this chronic inflammation leads to atherosclerosis, which in turn leads to stroke and coronary artery disease. Okay, so this is how the cycle really operates. Okay, now remember, we talked about fat in the liver, we talked about fat in the pancreas. Now I'll show you how fat in each of these organs leads to organ dysfunction. For example, right, these are the different organs. You can see there is fat deposited in the brain, there is fat deposited in the pancreas, in the adipose tissue, in the liver, in the skeletal muscles, etc. Okay, so the fat starts getting deposited in the liver, ectopic fat in the liver. This is what is known as metabolic associated fatty acid, or MASH or NASH, right, or non-alcoholic steatohepatitis, right, and it leads to insulin resistance. Fat gets deposited in the pancreas, that leads to beta cell dysfunction, can lead to pancreatic cancer also, right, and increased risk of pancreatitis. We all know type 2 diabetes have increased risk of pancreatitis. You have fat deposited in the epicardial region, lead to heart disease or heart failure. There is a condition now you have heard about called Ffpai, heart failure with preserved ejection fraction. So that is what is deposited, ectopic fat that is deposited. You have fat in the renal sinus that contributes to renal failure. You have fat in the perivascular fat that leads to endothelial dysfunction, and you have fat in the brain that leads to dementia and Alzheimer's and the other forms of loss of memory, right? So all these things, ultimately the problem really is the ectopic fat, right? It's the fat which is the problem, which is something which can contribute to all these problems, right? Okay, now so you have fat in the muscles that leads to peripheral insulin resistance, fat in the pancreas that leads to what is now known as non-alcoholic fatty pancreatic disease. You have fat in the epicardial region. So this is the epicardial region of the heart, and this fat here ultimately leads to epicardial fat leads to heart failure. And then you have perivascular fat. This is what contributes to endothelial dysfunction, right? And then you can see in this very nice pathophysiology photo, you can see a normal heart. This is normal heart. This is heart failure with preserved ejection fraction. So you see a lot of fat here. You can see the size of the heart also, and you can see the fat. And then you can see heart failure with reduced ejection fraction. So again, see the size of the heart. This yellow color is basically the fat. So you can clearly see how much fat is being deposited in this tissue. Then you have fat in the kidneys, that is renal sinus fat. I'll show you another elegant picture. You can see here in panel A, you can see fat is, these are MRIs where you can clearly see the fat is there in the lot of fat in the renal sinus region, whereas in a normal person there is less amount of fat, right? So you can clearly see the difference in this fat. And then fat in the various other organs. In the brain, it can lead to stroke and dementia. In lungs, it can lead to COPD and sleep apnea, and vasculature leads to endothelial dysfunction. So these are all, so ultimately fat is ectopic fat is the problem which you are dealing with, right? Now, how did we start understanding ectopic fat as a problem, right? Now you have heard a lot of companies nowadays claim diabetes reversal. Well, I think we can have a discussion completely, a lot of it is fake. Okay, a lot of it. It is possible. See, diabetes remission and reversal, type 2 diabetes remission and reversal is possible. It is very difficult to achieve, right? And a lot of these companies claim that, so many people diabetes got reversal. That is all fake, right? What is reality is that it is possible to have diabetes remission. But what you have to understand is that to achieve this diabetes remission, and that is what Dr. Roy Taylor, you can say is a father of diabetes remission, right? He's the person who did the direct trial, okay? Now, one of the fundamental principles of the direct trial is, a lot of people, talk a lot of nonsense about this, but I think the most important thing is he talks about this twin cycles. Okay, the twin cycle, what he's saying is that there is one fat cycle in the liver and there is one fat cycle in the pancreas. Now you have fat deposited in the liver and fat deposited in the pancreas. Okay, so if you can reduce the fat, reverse the fat from the liver and reverse the fat from the pancreas, you have reduced insulin resistance and you have better beta cell function, and ultimately this combination leads to diabetes remission. Okay, so what he's saying is that the beta cell dysfunction, and so if you reduce the fat, So the best way of reducing fat is not in, there is no specific way that I just want to remove the fat from the pancreas or I just want to remove the fat from the liver, right? That is not possible. Rather, you have to reduce body's overall fat. So he said that in their study, or the counterpoint and direct study, what they did is basically overall reduce the fat. So overall you reduce the fat. This is what they did in the direct trial also. So overall, if you can reduce the fat, you also reduce the fat from the liver and the pancreas, and that is ultimately what leads to diabetes, right? So their theory was very simple. If you lose 15% of your fat, of your body weight, then you are more likely to achieve diabetes remission, right? So that is something which is very, very important, right? Now you say that again, ectopic fat is something which is very important, and the disease basically is because of ectopic fat. So how do you measure this ectopic fat, right? Now there are many ways of doing it. One is you can clinically measure it, you can use biomarkers, you can have radiological markers also. So clinically, one is of course, BMI. Of course, naturally somebody with a higher BMI is more likely to have a higher amount of ectopic fat, but this is not always so. There is another marker which I'm just going to talk to you about. You can measure the waist circumference. This is where I'm going to come in a few minutes. You can measure waist hip ratio, and you can base, and this is the one which is very, very important, waist to height ratio, right? I think if you see the new concept and which is now emerging, the very, very important concept is waist to height ratio, right? Very, very important fundamental concept is waist to height ratio, right? This waist to height ratio is something which ultimately is very important as far as the diabetes related or the obesity related complication is concerned, right? Now what is waist to height ratio? So you measure the waist circumference, measure the height, calculate the ratio, and if the waist circumference is greater than is waist circumference more than half of the height, right, that means it is something is wrong, right? You have more ectopic fat. Very, very simple marker. So if let's say, how do you measure waist circumference? What size pants you wear, right? So if the size of the pant you wear is more than half of your height, that means you are in a problem. So if very simple marker to estimate, forget BMI or the thing, the marker you have to measure, the marker you have to focus on is waist to height ratio. Why this is important? Because studies have shown that is waist to height ratio is a very good correlation with ectopic fat, right? So those people who are more likely to have more waist to height ratio have more ectopic fat, and they are more likely to develop diabetes and its related complication, right? So this is something which is very, very important. Now you can do certain images to measure the ectopic fat, MRI, MR spectroscopy, CT scan. Sometimes you can do USG, right? You can do certain type of PET scans also to measure the ectopic fat. So these are all imaging techniques. Of course, you are not going to do that. It is as a part of routine practice. You can do it mainly for clinical studies, okay? So there are a lot of these things, and then you can measure ectopic fat using various lab reports. There are some certain very specialized tests called lipidomics. Simple way is to measure triglyceride level, HbA1c level, HSCRP level. I think one thing which is very useful is triglyceride, right? So I think again very simple to understand. Those people with higher triglyceride have more ectopic fat, right? This is something which is very, very, very important to understand, right? So this is something which is important. So if your patient has very high, let's say patient has 300 triglyceride, 400 triglyceride, that means the ectopic fat is also high. Also, these are the patients who are more likely to develop pancreatitis also. And remember, pancreatitis also is linked with the ectopic fat. Okay, so these are all some things which are very, very important to understand. And this is, like I tell you, triglyceride and HbA1c, these are very strong markers of ectopic fat. HSCRP is not a marker of ectopic fat per se; it's a marker of inflammation associated with fat. So more HSCRP means there is more inflammation. Where does the inflammation come from? It comes from the ectopic fat, right? So it's an indirect marker of that. But technically, if you have fat but it is not theoretically under-inflamed, then HSCRP may not be high, but most cases it is. So that means that is something which there is a correlation. Now you can ask me, how do you reduce the ectopic fat, right? What are the ways in which you can reduce the ectopic fat? So we have all discussed. So ultimately, the point is, how does our patient become better? How do we become better? Okay. So there are many, of course, usual strategies. You can do lifestyle measures, pharmacotherapy, and obesity surgery. These are all means of, reducing ectopic fat. So lifestyle measures, right? Studies have clearly shown that, exercise reduces ectopic fat, right? This has been shown in a lot of studies. How much weight loss? About 5 to 10% weight loss is effective in reducing ectopic fat. That is the general output. But if you want to remove the fat from the pancreas, then you need to reduce 15% weight, right? That is something important. But about 5 to 10% is enough to reduce fat from the epicardial fat and the liver fat. All this fat can be reduced by about 5 to 10% of weight loss. Amongst the pharmacological therapy, right, these are the drugs which are known to reduce ectopic fat or impact ectopic fat, right? Amongst anti-diabetics, these three drugs. Now, pioglitazone does not reduce ectopic fat. I'll just come to this point. It does something else. SGLT2 inhibitor and GLP-1 receptor agonists are the drugs. See, in future, I'm telling you, after 5 years, you are not going to hear about metformin. You will not hear about sulfonylureas. The only two drugs which will stand the test of time for a long time are these two drugs. Why? Because these two drugs actually reduce ectopic fat. They are the drugs which reduce ectopic fat, and by reducing ectopic fat, they actually target the main problem in type 2 diabetes, and this is what I'm trying to discuss. Pioglitazone does not reduce ectopic fat. In fact, it actually increases the fat in a sense, right? But what it basically does is increases the number of adipocytes. So I told you earlier that the adipocytes are fixed in number. But by using drugs like pioglitazone, you can actually increase the number of adipocytes. So by increasing the number of adipocytes, what you're doing is the fat starts getting redistributed amongst other cells. So the fat cells are less under stress. This is exactly what I was trying to tell you in the very beginning, right? So, just understand this concept, right? So let's say these are all cells, right? Let's say that these are 3 cells and all of them are stuffed with fat, okay? Now, what pioglitazone does is it increases this 3 cells into 6 cells. So by increasing the number of cells, the amount of fat in each cell is redistributed. So the fat remains the same and the patient may actually look more obese, but the fat is now redistributed, right? There is redistribution, and because there is redistribution of fat, this has more inflammation, this has less inflammation. And ultimately I told you that the problem is related with inflammation at the end of the day, and hence pioglitazone reduces that. Pioglitazone redistributes the fat amongst the adipocytes, and hence it leads to the disease solution which we ultimately discussed, right? So pioglitazone is still a very important drug, right? And it's a unique action. The other drugs don't have this action. And then you have newer drugs like thyroid receptor agonist. You would have all heard about the drug which is called resmetirom. Resmetirom was the first drug which was approved for non-alcoholic fatty liver disease, right? The first drug approved for that. And you'll hear more about this. Right now it's still in early phases and it's not available in India. So those of you who follow notes in endocrinology can scan this QR code and you can read our notes on resmetirom, right? So resmetirom is something which is a new drug which has been approved for use of non-alcoholic fatty liver disease. What about bariatric surgery? Absolutely, yes, bariatric surgery reduces ectopic fat to a significant extent, and that is something which is well known. And obviously it's a surgical technique, right? But end of the day, it reduces and there are different types of surgery will lead to different amount of ectopic fat reduction. So to conclude and take home messages, I'm just going to give you some conclusions from my end. First and foremost is the unifying theory for diabetes, right? Understand diabetes. Remember, diabetes is a disease of imbalance between insulin resistance and insulin production, right? So this is what ultimately diabetes is, right? So when you have more insulin resistance than the insulin that is produced, you have development of the type 2 diabetes or development of any form of diabetes. Okay. Secondly, you have to remember that type 2 diabetes is a disease of ectopic fat. So you have fat in the liver that leads to central insulin resistance, fat in the pancreas that leads to beta cell dysfunction, and all the diabetes related complications are also because of ectopic fat, right? So you have the renal failure, the cardiac disease, the stroke, everything that you are associating with diabetes are linked with ectopic fat. And ultimately the third point is that your treatment should be directed towards reducing the fat, right? So reduce the fat. And how do you reduce the fat? You can do it by lifestyle measures, by reducing weight of the patient overall. Secondly, you can do it by using certain drugs like SGLT2 inhibitors or GLP-1 receptor agonist, right? So these are all drugs you can use to reduce the ectopic fat, right? And ultimately, if nothing works, you can go for bariatric surgery. And that's why we know bariatric surgery leads to diabetes remission also, because it reverses this ectopic fat. So I thank you for a patient listening. And we have this WhatsApp channel called Endocrinology India. You can use this QR code. If you're interested in more about endocrinology, we keep posting updates every day. I also do a lot of technological things also. So this is something which will be very useful for that as well. And I'm there on Twitter. So those who, I keep posting everything that I do on Twitter as well. So if you're, somebody who likes being on Twitter, now it's called X apparently. So you can follow me there. We have about 12,000 followers there. So thank you for a patient listening. And if I don't know if we can take some questions, we'll be happy.
Yes, sir. Thank you very much, Dr. Om Lakhani. This was really mind-blowing, I should say,
Thank
to
you,
give the different concept. And you gave us, we were witness to your technological expertise also by on every slide you were mentioning and explaining to us very clearly. So we have understood the concept of type 2 diabetes very clearly today. Thank you so much for that. And
you.
I do not see any questions on the YouTube. I have one or two questions for you.
Sure, ma'am. We'll
Okay.
be happy to take them.
Yeah. So you mean to say that, I mean, this is just to ensure what you said, reiterating to all of us and also to the viewers. So diagnosis of pre-diabetes and tackling it by lifestyle moderation or medicines at that stage is very important. And one of the factors for doing that will be HbA1c, triglycerides. So the annual checkups are
Yeah.
important because very often these questions come, why should we keep doing an annual checkup? It's a waste of money. So this is where it is important. And my specific question is, can HSCRP be controlled and brought down? Can we keep a track of that and see that the inflammation in a particular patient has come down?
Yeah. So I think both great points and great question. I would say to answer your first question, yes, routine health checkups are important, but it's also very important that we intervene, right? Not just so that is one of the problem with is that there are a lot of patients get a lot of tests done, but then they don't do anything about it, right? So that's something which I don't think it's always a doctor's fault. Doctors tell them, but patients don't do anything. They don't take it seriously, right? I think that is where once the blood sugar starts appearing in 3 digits, 200s and 250s, that is when they start taking action. Ideally, again, the action should be taken when it was 100, 110, right? So this was the point where the action should have been taken, right? Same with HbA1c as well. So yes, these tests are important because this is the time when you start intervening. Like I said, pre-diabetes stage is when the complications of macrovascular complications start seeding in the pre-diabetic stage itself, right? So if you want to prevent a heart disease or if you want to prevent the patient from having stroke, you start intervening at the pre-diabetes stage, right? Now, how do you intervene? Of course, lifestyle measure is something you start with, and then if that doesn't work, you can even consider medications at this stage as well. So it is very important that these are the stages where you pick up this patient and explain to them the importance of treating at that level rather than waiting for the patient to start developing full-blown diabetes. To answer your second question about HSCRP, so what we need to understand, if you see the chronology of things, one, you have fat that is deposited, and then this fat is under stress, and this fat under stress leads to chronic inflammation, and that is where the HSCRP starts increasing, right? So this is the sequence of events that happen. So when the HSCRP has started to increase, that itself means that the chronic inflammatory stage has started. Now, how do you reduce that? Now, we have to understand that HSCRP is a marker and not a target, and this is something we have to differentiate. Same with triglyceride. So a lot of people say that the clinical trials where they have reduced triglyceride has not shown cardiovascular risk reduction, so why should we reduce triglyceride? No, I'm not saying that. What I'm saying is that when the triglyceride is high, it means that the patient has more ectopic fat, and I'm not saying that you reduce triglyceride. I'm saying that you work on the patient as a whole, and as a result of that, the triglyceride will reduce, and hence it's a marker, not a target, right? So that's something. Same with HSCRP. HSCRP is a marker and not a target, right? So we are not specifically trying to reduce HSCRP. We are specifically trying to understand that the patient has that chronic inflammation and to correct that process. So a patient with a high HSCRP means that there is fat and this fat is under stress. So what I'll do, I'll start the lifestyle measure or intensify the lifestyle measure, insist on the patient to lose weight. By losing weight itself, the patient's HSCRP levels will come down. And in certain cases, again, statins, we know, are known to reduce HSCRP as well because they have that mild anti-inflammatory action, right? Metformin also is known to reduce that. So there are drugs which you can use, right? But the drugs are not targeting HSCRP. The drugs are basically targeting the underlying pathophysiology, and that is basically the ectopic fat, right? So that's the ultimate idea. So yes, you can trace HSCRP. In fact, some of the trials for rosuvastatin actually use this as a marker as well. It's not very convincing because that HSCRP, like I said, is more of a marker than a target. So that is where we need to differentiate. But yes, it is something which you should consider seriously. And if you're amongst your investigation panel, HSCRP, not a very expensive test, it is something you can consider as a part of the entire panel as well.
Earlier in our undergraduate days, we used to think it is genetic factor and it cannot be changed. So that concept is gone. Now, waist to height ratio, what you told,
Yeah.
at what stage and how by, this is the apple pear body, what we talk about. It's the
Yeah.
same thing you're talking about. A
Yeah.
little
Yeah. So
more
it's
clarity on that.
correct. So the point ultimately is that the waist circumference, if your waist circumference is higher, that means that you have more of visceral fat. So the waist circumference is an indirect marker of visceral fat. Now, like I said, you can of course directly measure visceral fat by doing a CT scan or a DEXA scan, but because those are very expensive and they'll curtail a little bit of radiation exposure, the simplest anthropometric way is to measure the waist circumference. So that's the what we call it as a apple-shaped obesity, as we all used to call it. So the apple-shaped obesity meaning that there is more central fat, there's more belly fat. This belly fat, central fat is indirectly linked with more visceral fat. This has been clearly shown that those people who have higher waist circumference have more visceral fat, and more visceral fat ultimately is the marker of the ectopic fat, right? So that is again indirectly a marker. Now the problem with BMI, of course BMI is a good marker, but the problem with BMI is that if somebody has a higher muscle mass, right, his weight will be more, and hence again, he might have a higher BMI. Yeah. Secondly, even amongst the fat, somebody with a more subcutaneous fat will also have higher BMI. Whereas the problem is not the subcutaneous fat, the problem is visceral fat. So Indian patients, somehow, if you see them, their BMI may not be very high, but they have a big central obesity, right? And that is what ultimately they are more at risk compared to somebody who has less of belly fat, right? So hence, it is very important to understand that the waist circumference is one marker, and this has been repeatedly, I have seen so many. I have personally seen a lot of UG students, PG students, understanding this. A lot of PG thesis, both in endocrinology, in medicine also, are on waist circumference and is linked with metabolic complication. Every student understands, every doctor understands, but we in clinical practice we don't even measure waist circumference. So that is something which is very common,
routine.
and it's a very important marker and very easy to measure also.
So there is a question on YouTube: the importance of saroglitazar in fatty liver without diabetes, and another question is reducing the ectopic fat.
Yeah. So saroglitazar I'll tell you the pros and cons of it. Saroglitazar, I'll tell you in my personal opinion, it's a very good drug for exactly for the purpose which it was stated. It is now among Indian clinical trials found to reduce the SGPT and SGOT in patients with non-alcoholic steatohepatitis, and smaller studies has also been shown to reduce fibrosis, right? So it's a good drug. It can be used in diabetic as well as non-diabetic NASH and FLD. It also reduces triglyceride, but again remember, marker, not a target, right? So that's something which I feel again the differentiation lies here. So it's a very good drug. The problem with saroglitazar is that it's an Indian drug, and the clinical trials have not been done in the West, right? They're still undergoing trials there. So unfortunately, it's a very good drug, and I think when you have a patient in a pre-diabetic stage with high triglyceride, high SGPT, fatty liver, that is the time you can actually start the patient on saroglitazar, and the patient will have wonderful effect. I have seen a lot of patients do very well just on that for a long time. Do not develop diabetes, I have patients on follow-up for almost 7 years on saroglitazar alone, and they were right at the cusp of developing diabetes, and they're doing very well now. So it's a good drug. Unfortunately, we don't have that much of clinical studies from the West, and that's because of that it does not get that much prominence in Western textbooks and literature. But it's a good drug, and I think once they do a clinical trial in the West, which they're already doing, we might have more understanding of that. As far as reducing ectopic fat is concerned, there are no like I said, there are certain drugs which work. SGLT2 inhibitor beautifully works. In fact, I think the mechanism of SGLT2 inhibitor working is reducing ectopic fat. It reduces ectopic fat from everywhere, and all the organs where it reduces ectopic fat, you have found that SGLT2 is beneficial. For example, it reduces fat from the epicardial region, and you know that SGLT2 are the only drugs which have been approved in HFpEF. Right. Secondly, it reduces the fat from the liver, and now there have been studies where they have shown that it helps in fatty liver also. It reduces fat from the pancreas, and you see a lot of patients on SGLT2 inhibitor have remission of diabetes eventually. So that is also contributed to that. It's in fact one of the major drugs used by nephrologists also, because it prevents kidney disease, prevents complication. Again, they have shown in studies that it reduces ectopic fat from the from the kidney also, the renal sinus fat also. So all this ultimately is something, we know that SGLT2 works. in a perfect way, right? Again, of course, barring the side effects of the drug, I think it's a very good drug to use. Same happens with GLP-1 receptor agonist. GLP-1 receptor agonist, another advantage of GLP-1 receptor agonist is that overall it reduces the fat, plus it also reduces inflammation, right? A lot of these drugs, SGLT2, not so much. GLP-1 reduces fat and inflammation, and that's why it's very effective in atherosclerosis prevention, right? So again, one drug which is very, very useful. But apart from that, reducing ectopic fat, your usual measures like lifestyle measures, bariatric surgery, etc., can be as effective and as useful.
How long does you have to continue saroglitazar?
Well, I would say continue lifelong. A lot of these patients we continue for a long time. Again, it depends on the indication for which you're using. So if you're using it for fatty liver and NASH and FLD, you give it for a long period of time. The one time I consider stopping saroglitazar is when the patient starts having good weight loss. So if the patient has lost a good amount of weight, let's say, patient came to me and patient was very motivated and patient lost about 10 to 15 kgs. Then I say, okay, fine. We sometimes discontinue saroglitazar in a lot of these patients, but for those patients who are not motivated, who don't lose weight, in such cases you can possibly consider continuing the medication.
So the role of body fat analyzers, some of these centers have that body fat analyzer. So is it better than waist height ratio?
Yeah, so most of these, these body fat analyzers use impedance, technique for measuring the body fat, which in itself is found to be inaccurate. Now, even amongst that, there are certain techniques and there are certain algorithms which actually are better. So even in that body fat analyzer, there are certain body fat analyzers which are good and which are actually the body impedance technology that use is good. They are more expensive, but they are quite reliable, right? But again, having said that, it is not gold standard. So the body fat analyzers that we have in gyms and in doctors' offices, we are cheap ones. They may not be very, very accurate, right? There are more sophisticated ones which are used in research laboratory and all that, which are very effective, and big hospitals also you have that, which are quite useful. But again, the gold standard is still DEXA scan. So if you have a machine, DEXA machine, I think that is the one which should be used as gold standard for measuring ectopic fat.
Thank you, sir.
Today's talk was really eye-opening session, sir.
Thank you, sir.
Lots of new ideas we can say about diabetes we come to know, and it will definitely improve our practice while we are giving treatment to diabetes patient.
Absolutely. Thank you.
Dr. Om, there is a suggestion that you take a class on glucotoxicity and lipotoxicity. And of course, there are a lot of, appreciating messages on the YouTube.
Thank
yes,
you.
sir. Yeah,
lipotoxicity and glucotoxicity is something I talk about in every talk of mine. It's my pet peeve. Definitely. I think we can, if we continue the series, we'll have a dedicated talk on these.
We will definitely continue the series and we will have it. So, could you, if you don't mind, could you just type out your email ID in the chat box, or you just tell?
Sure. Yeah. So, my email ID is very simple, dromlakhani@gmail.com.
Okay.
I think, yeah. So, yeah.
Yes. Thank you. So,
Thank you,
thank you, sir. On behalf of the all the speakers, the president, the secretary, and all of us, on behalf of Dr. Sanjay Shah, I extend a very heartfelt thank you and a gratitude to you. It was a very enlightening session and very illuminating. And the way you drew the diagrams and showed, it just hits the nail on the head. And thank you, viewers who are all watching with us. And this is still present in the YouTube channel. You can always go and get your revision done again. The more you listen and you get a better picture of diabetes, type 2 diabetes. Thank you, Rahul, and the backend team who supported for this webinar. Thank you, everyone. Thank you, Dr. Sanjay.
Thank you.
Thank you, everyone. Dr. Om, there are no words than which we can thank you.
Thank you so much. Thank you, ma'am. Thank you, sir. And thank you for having me for this. Thank you.
We will have more of this.
Thank you. Goodbye. Thank you.
Goodbye.